Okay, good morning. My name is Christine Andeni, and I'm one of the co-directors of Grand Rounds with Drs. Jeff Miller and Kate Elkington. And today, Dr. Jeff Miller will join me on Zoom in co-moderating this special lecture. We have a few announcements before we begin today. Next week's Grand Rounds will be in person with a Zoom option and will be given by Dr. Christoph Kalendonk, Professor of Molecular Pharmacology and Therapeutics in Psychiatry here at Columbia. And the title of his talk is Using the Mouse to Study Neuronal Mechanisms with Relevance for Schizophrenia. Following that lecture, we're having a different lunch as we're starting this week. We will hold a lunch for trainees specifically to speak with Dr. Kalendonk from 12:30 to 1 p.m. in the multipurpose room here on the 6th floor. Registration is required, and the link to register for this lunch has been distributed already and will be again. Please sign up if you are interested. For today, I want to encourage everyone joining via Zoom to post questions at any time during the talk using the Q&A feature at the bottom. Please do not use the chat window. If you are a trainee, please put the word trainee at the beginning of your question, as we will prioritize these questions. We encourage Zoom attendees to ask questions themselves. Jeff can promote you to panelists in a Zoom webinar for this purpose. So please write, "Can ask question myself," or prefer to have my question read at the end of your question. I'm now going to turn it over to Dr. Francis Levin to introduce our speaker for this special lecture today. Thank you.
Good morning. It's my pleasure to welcome you to the 8th annual Eric D. Hadar Lecture. As you heard, my name is Francis Levin, and I'm the director of the Division on Substance Use Disorders at the New York State Psychiatric Institute and CUIMC. The Hadar Lecture began in 2016 through a generous gift of $2 million from Eric D. Hadar and the Eric D. Hadar Family Foundation. The gift established an endowed fund to support the Eric D. Hadar Lecture, an annual lecture series focused on substance use disorders, and the Eric D. Hadar Research Fund, which advances research by providing resources for faculty support, research projects, and laboratory infrastructure, as well as supporting the careers of young investigators through the Eric D. Hadar Fellowship. We are very grateful for Eric's partnership in this area and his foresight in establishing these funds, which are instrumental in not only facilitating pioneering research, but also effectively distributing information in the field of substance use and substance use disorders. These lectures, such as these, allow the division to foster collaboration and to disseminate the most promising discoveries in the field to colleagues across our institution and throughout the scientific community. The annual lecture is in memory of Dr. Herbert Kleber, a compassionate clinician and unparalleled leader in the substance use disorder field. So now let me introduce Roger, a close friend and colleague. The title of his talk is Integrating Pharmacotherapy and Behavioral Therapy in Treating Patients with Substance Use Disorders. Dr. Roger Weiss is a professor of psychiatry at Harvard Medical School and the chief of the Division of Alcohol, Drugs, and Addiction at McLean Hospital in Belmont, Massachusetts. He's been an extremely productive researcher and has contributed a great deal to the substance use disorder field, as evidenced through his authorship of over 400 articles and book chapters, as well as 4 books, and he also serves as a journal editor on several editorial boards. He's the principal investigator of numerous NIDA and NIAAA grants, and has developed integrated group therapy and evidence-based treatment for patients with co-occurring bipolar disorder and substance use disorders. Dr. Weiss led a multi-site national study of the treatment of prescription opiate dependence, which is part of the NIDA Clinical Trials Network. And he is currently working with his colleague, Dr. Ned Nunez, as a lead investigator on a multi-site retention, duration, and discontinuation study examining optimal treatments for opiate use disorder, and this is also part of the CTN. He's received numerous prestigious honors, which you can read in the pamphlet we've put out in the back, and he's participated in prominent national committees, such as serving as the vice chair of American Psychiatric Association Task Force on Practical and Practice Guidelines. Please join me in welcoming Roger. I'm delighted he's here. We had a wonderful dinner last night. It was really fun. And it's a pleasure to invite him to speak today. He's been a longtime colleague of many of us in the division. Thanks, Roger.
Thank you, Fran, for that really nice introduction and for inviting me. This is a great honor, and thank you to Mr. Hadar for supporting this lecture and so many other activities. I think it's just terrific, and it's great to be here where I know so many people, lots of friends, colleagues, friends and colleagues. So why don't I'm going to get started. So I'm going to be talking about integrating pharmacotherapy and behavioral therapy in treating patients with substance use disorders. This is my disclosure. So what are the goals of behavioral therapy when you're being delivered in addition to medication treatment? First one is medication adherence, defining and attaining the goals of the patient with the substance use disorder, whether it's abstinence or reduction, and dealing with other problems, mental and physical health, interpersonal issues, work, school, housing, etc. Behavioral therapy can be delivered by the prescriber and or by an additional therapist or counselor. I'm going to use the term medical management a lot today, but as I'll be talking about that, I think it's not the best term. I think medical counseling is a better term, and I'll talk about that a little bit later. So job one is medication adherence. So medications only work when you take them. Lots of people don't take them. So the question is, why? And I think there's a number of categories of reasons why people don't take medications. One is related to the medications. Either they're not effective or the patient thinks they're not effective. They cause intolerable side effects, they cost too much, or the regimen is too complicated for them to figure out how to deal with it. This, regarding the latter one, this is a study that showed that the less often people have to take medications, the more often they actually take them as prescribed. So a second reason why people don't take medication is related to the patient. They either don't accept that they've got the disorder that the medication is for, they don't have a plan or a poor plan for the medication adherence, they don't understand the need for consistent dosing, they have misconceptions or fears about the medications, or they're forgetful, either related to the disorder or the medication causes forgetfulness. It could be related to their substance use disorder. Sometimes they may take too much because they want to get high with the medication. The medication on the flip side may interfere with their getting high and they don't want that. Or they don't want to mix alcohol and drugs with medications. Could be related to social support. Could be family or friends or peer support groups that discourage the use of medication, or that there's a perceived stigma attached to taking the medication. Could be related to the prescriber. Maybe the prescriber is not sure that the treatment is effective or communicates poorly about the rationale, the risks and benefits, or how to use the medication. Or it could be the patient, psychiatric reasons, that the patient is so depressed or pessimistic about treatment that they think it's not even worth taking it. We did a recent study at McLean Hospital on optimism in inpatients and showed in our inpatient unit that our patients had the lowest scores on optimism of any population that had ever been tested. In between our submitting that paper and now, one group has found to be more pessimistic, which is Australian police officers. For whatever reason. And finally, inpatients waiting for the medication to work, so they take too much. So non-adherence does not always mean taking too little medication. In a study that we did, series of studies that we did on patients with co-occurring bipolar disorder and substance use disorder, one of the studies that we did, we gave people a list of a variety of different psychiatric medications, and we asked them, over your lifetime, how often have you taken this medication as prescribed? And people could answer anywhere from never to 100% of the time. And then the second thing we asked them is, if you didn't take something as prescribed, what was the primary reason that you didn't? What you see here, lithium, the most common reason was physical side effects or denial of illness. They saw no need. But you can see both with lithium and with valproate, some people wanted to use alcohol or drugs and they didn't want to mix the two. If you go down to the bottom, what you see is with benzodiazepines, the most common reasons that people didn't take it as prescribed is that they took more. They either took more because they wanted to get high, or they took more because they were impatient waiting for the medication to work. But that's no great surprise that people would take benzodiazepines more than prescribed, but medications that we don't typically think of as medications that people misuse, neuroleptics. 26% of patients who were not adherent took more. They were either impatient waiting for it to work, modify the effects of substance use, like they used cocaine, so they took some extra antipsychotics for paranoia, or to get high. The sedating or anticholinergic effects of some antipsychotics are appealing to some people. A lot of people here, on the younger side, don't remember the medication Mellaril, which was an antipsychotic that was taken off the market back in the late 80s or so. It was one of the first generation antipsychotics, a pretty dreadful medication that most people really hated because it had terrible anticholinergic and sedating effects. Patients on our unit called it Melithril because they liked those effects. Tricyclic antidepressants. Most of the reasons for not taking them as prescribed is people took more than prescribed. They'd say, I'm supposed to take 50 milligrams of disipramine, but I'm really depressed. I'm going to take 200 milligrams today. So what are some strategies to increase medication adherence? So I think there's three major categories of that. The approach to the patient, external reinforcement, such as family interventions, and prescribing patterns. So one of the first approaches is actively discussing adherence issues. So before I did that study that I just talked about with reasons why people didn't take their bipolar meds as prescribed, I would ask people, are you taking your medication? If they said yes, I would then say, well, are you having side effects? How's it working? After that study, I'd say, are you taking your medication? Yes. How much are you taking? And very often, people were not taking what was written on the prescription pad. I always think when you write a prescription, the letters PRN are always implied, if not written. So people will take whatever they want, whenever they want, in whatever dose they want, and that you need to specifically ask people how much they're taking. People will volunteer it, but they won't just tell you, but if you ask them, they'll say, oh yeah, I doubled my dose because I was really depressed. I cut my dose in half because I thought things were going better. So sometimes these things make a great deal of sense. Sometimes they're very risky, but without asking specifically, a lot of times people just won't tell you. Illness education, of course, why the patient needs medication, asking about obstacles to adherence, such as comprehension, emotional reasons, complexity of the regimen, cost, and behavioral aids, telling people to put yellow stickies on their bathroom mirror, setting their watch or their phone alarm to take medications if they have to take them a couple times a day. External reinforcements, which I'll talk about in more detail in a minute, include working with the family, educating them, because families can either support people taking medication or support their stopping their medication. And so, I'll give an example of a disulfiram contract and contingency management, for example, rewarding patients for taking medications. And then prescribing and dosing issues, simple regimens, pill boxes so that people can keep track of what they're doing, longer acting or forgiving medications, and depot medications such as injectable buprenorphine or naltrexone. So now I'm going to talk about specific examples, and we'll start with alcohol. So there's 3 FDA-approved medications for alcohol use disorder: disulfiram, better known as antabuse, naltrexone, and acamprosate. So disulfiram inhibits aldehyde dehydrogenase, which is part of the metabolism of alcohol. And so it's like putting up a dam in the middle of the metabolic process. So if you take in alcohol, either by drinking, the most common form, or in disguised form, such as cough syrup that has alcohol in it, you will get acetaldehyde poisoning about 10 to 15 minutes after drinking. Non-adherence is very common. It's much more the rule than the exception with people who are prescribed disulfiram. And disulfiram is only suitable for patients seeking abstinence. It's not for people who are looking to reduce their drinking because they'll get sick on a regular basis. So how to help people actually take it? So a psychologist who was at Harvard Medical School named Tim O'Farrell developed what he called an antabuse contract. He worked in a VA hospital, so it was almost exclusively male patients, and they set up something with these patients and their wives called the disulfiram contract that went like this. They were given a script, and the script went like this. Each morning, the wife would say, "It's time to take your antabuse, honey." And he would say, "Thank you for reminding me to take my antabuse, honey." You can imagine what these conversations were like through gritted teeth. And then he would say, "I'm taking my antabuse now and I promise not to drink today." He would then take the antabuse. She would say, "Thank you for taking your antabuse, honey." He would say, "Thanks again for reminding me." So this is known as mutual thanking. So even though these conversations were very tense and they didn't really feel all that thankful, a couple of things happened. One, sort of remembering Psych 101 and the idea that if you say things often enough, you start to believe them. If you say thank you often enough, you begin to feel grateful. But the other thing that happens is he's taking his antabuse, he actually doesn't drink that day. She therefore isn't constantly sniffing his breath, looking under the bed for the bottles, so she can relax. As she relaxes, he relaxes, and things start to actually get better. There's one other part of the disulfiram contract, which is the couple are not allowed, no discussions of past or future drinking outside of meetings with the therapist, because there's never in the history of the world been a conversation about past or future drinking between a couple like this, where afterwards they both said, "I'm really glad we had this chat." So what happens as the result of the disulfiram contract? A, drinking is reduced. Greater marital satisfaction, less intimate partner violence, and better functioning in their children. So this was a very effective intervention, both for the patient, the family, or the marriage, and their kids. Naltrexone very different medication. Its mechanism of action is that it may reduce alcohol-induced craving, or the so-called priming response, where essentially the first drink tastes like more, and alcohol reward. So it doesn't reduce the likelihood of any drinking, but it does reduce the likelihood of heavy drinking. So it helps contain a slip or a lapse rather than leading to a full-blown relapse. It comes in oral and extended release injectable form. And like with disulfiram, non-adherence is very common. And when there's poor adherence, the outcomes are poor. So cognitive behavioral therapy has been used with naltrexone for alcohol use disorder. One of the advantages of CBT is that it includes a discussion of the abstinence violation effect. So the abstinence violation effect basically is as follows. I've been abstinent for 3 months and I took a drink, I may as well just drink the whole bottle. So that's a very common thought process that occurs in people that start drinking after a period of abstinence. And CBT for alcohol use disorder anticipates that, discusses it, and says, if you've been sober for a while and you take a drink, you will be tempted to drink the whole bottle, but you need to fight that urge with every bone in your body. So it, to some extent, is similar to the mechanism of naltrexone, which increases the likelihood that a lapse does not turn into a full-blown relapse. So in one of the best studies of naltrexone plus behavioral treatment, Ray Anton at the Medical University of South Carolina had studied 160 patients who were given either naltrexone or placebo, and they were randomized to either cognitive behavioral therapy or motivational enhancement therapy. The naltrexone patients did better than the placebo patients with a longer time to relapse, and the patients who got naltrexone plus CBT had the best outcomes, better than naltrexone plus motivational enhancement therapy. There's some conflicting studies on the specific value of CBT with naltrexone, but in general, that is seen as probably the best behavioral treatment to give along with naltrexone. Acamprosate is the third FDA-approved medication for alcohol use disorder. Its mechanism of action is to interact with glutamate and GABA neurotransmitters systems that may reduce protracted withdrawal symptoms. Its big problem is that it requires 3 times a day dosing. So how do you get people to adhere to 3 times a day dosing? So there's a colleague, Rick Reese, who's at the University of Washington, who came up with this sort of cool idea, which he tells people, you're taking acamprosate, you have to take it 3 times a day. So I want you to use the TID method so that every time you take your pill, you say, today, that's the T, that's the I, take my acamprosate and there's the D, do my recovery plan. So you spend 1 minute basically thinking about, why am I taking this pill? So you can either do a mindfulness exercise, recite the serenity prayer, do something that is recognition of why you're taking this pill, and trying to turn the lemon of TID 3 times a day into lemonade, which is that each pill-taking experience becomes a therapeutic experience and not just taking the pill. The NIAAA combined study is the largest study that has looked at combinations of medications and behavioral therapy. 1,300 plus patients, 11 sites. I was part of that study. So patients received either naltrexone or acamprosate or both or neither. So 4 different pharmacotherapy conditions, all with and without psychotherapy, which was like best best practice psychotherapy called the combined behavioral intervention. So now you've got 8 possible cells. The main results of that study, naltrexone did well. The psychotherapy did well. None of the combinations did any better than no combination of medication plus therapy did better than expected. One of the interesting things about the study is that in addition to the 8 pharmacotherapy cells, we added a 9th cell, which was psychotherapy alone with no pills, no medical management. For 2 reasons. One, that's the way psychotherapy is typically delivered, not with placebo. Like, we're going to meet, I'm going to give you a placebo. It's just psychotherapy. The other is that it actually gave us the chance to study the placebo effect in alcohol use disorder, because you could compare psychotherapy alone versus psychotherapy plus placebo, plus medical management. So this is what we found, that the patients who got CBI, psychotherapy, plus medication management, plus placebo, did significantly better than people who got psychotherapy alone. This is the percentage of days abstinent at the end of treatment, 80 versus 67. As a matter of fact, this was the biggest effect that was shown in the whole study, the placebo effect. So why? What was it about adding medication management and placebo that did so much better than psychotherapy alone? So let's look for a moment at what are the active ingredients of medical management, which in this study was to be delivered by non-experts in addiction. The idea was you're allowed to say something that a well-meaning internist might say to a patient with alcohol use disorder, well-meaning but doesn't know anything about alcohol use disorder, but doesn't dislike the patient population. So somebody that's likes the patient but doesn't know anything really about it. So for example, if the patient said, well, I've been going into a bar 3 nights a week, the person's allowed to say, I don't think that's a good idea. We thought that that's something that doesn't really require a lot of specialized expertise to be able to say that. But that's the level of, like, this is as much intervention as you can do. So they would do an overall health check, advice to abstain from drinking, check on the medication and make sure they're taking it, and advice to attend AA meetings. Even if the patient in the first meeting said, I've been to AA, I hate AA, I'm never going. They still had to say, I think you should go to AA meetings, just because that's what the intervention was. As it turns out, the patients who went to medical management meetings did end up going to a lot more AA meetings than the people who didn't. So 32% of them went to AA meetings compared to 20% who just went to CBI. So there was an effect of advising somebody to go to AA week after week. And as it turns out, the people who went to AA did better. So that might have been part of the therapeutic effect of the medical management, which is really medical counseling. When we adjusted for AA attendance, the AA attendance wasn't everything. So AA attendance made a difference, but it wasn't the reason why people who got medical management plus placebo did better. So what else could there be? Well, there's medical management and there's taking pills. So pill taking itself is a daily reminder, just when I talked about the TID, it's a daily reminder of the reason that you're taking the pill. So it reinforces recovery efforts, and it's an additional benefit of medication adherence. If you take your medication, you're constantly reminding yourself the reason that you're taking medication. So let me talk about opioid use disorder. So as most people here know, there are three major treatments for opioid use disorder, pharmacologic treatments. You've got the full agonist of methadone. The more you take, the more agonist there is. You've got a full antagonist, naltrexone, no opiate effect, and then the partial agonist of buprenorphine. So I'm going to focus mostly on buprenorphine and behavioral interventions. So the Drug Abuse Treatment Act of 2000 in the United States said physicians must attest that they have the capacity to refer addiction treatment patients for appropriate counseling. Undefined. What is appropriate counseling? Things have changed. You no longer have to refer people to counseling, but it still does raise the question of what is appropriate counseling. So the prescription opioid addiction treatment study, which Dr. Levin mentioned that I had led, was the largest study of treatment of prescription opioid dependence, 600 plus patients at 10 sites. And we studied different lengths of buprenorphine and different intensities of counseling. And success was defined as abstinence or near abstinence from opioids. And we showed two things. One, people while they were on buprenorphine did much, much, much better than people when they weren't on buprenorphine. And the second thing was that adding counseling to buprenorphine and weekly medical management did not improve outcome. But ours was not just a one-off study in that regard. 4 major studies have shown that adding counseling to buprenorphine and medical management is not superior to buprenorphine plus medical management alone. Which raises some questions. Is buprenorphine that effective that you don't need anything? Is medical management that effective? Is counseling that ineffective for this population? And also, are there subgroups of patients who would benefit from additional counseling, including those with psychiatric disorders? So question number 1, is buprenorphine that effective? And when I'm asked that, I'd say compare to what? Buprenorphine versus no buprenorphine? Absolutely. Our study, 49% versus 7% success rate. The study of injectable buprenorphine sublocade versus placebo injection, 28% versus 3% success rate. So by a mile compared to no buprenorphine, yes. But compared to penicillin for strep throat, 28% success, 49% success. There's a long way to go. So we need to get much better numbers for this. Is medical management that effective? So again, I went through the active ingredients of medical management, but in all of the studies that I mentioned, the 4 studies, medical management in these studies was much more intensive than the community standard. In our study, it was every week. Other studies, it was either every week or close to every week. That's not the community standard, certainly not now. And when you have a big randomized controlled trial, the people who are delivering medical management tend to be the best people you've got. So medical management as delivered in these studies is really different from what you would see in the community. Are behavioral treatments that ineffective? Not all. So 3 randomized controlled trials have shown the benefit of behavioral therapy. All of them had either contingency management, computerized treatment, or both involved. There are a number of app-based interventions currently in use. Some of them offering contingency management within the app. We're using that as part of our NIDA Clinical Trials Network study. And so the jury's out on the effectiveness of these these on a large scale basis. There's also a difference between randomized controlled trials and real world results. So non-randomized observational and database studies can yield different results than you see from randomized controlled trials. First of all, the types of patients who enter these randomized controlled trials tend to be more motivated than most, because entering these trials is demanding. And so not everybody wants to do that. And you also get the research infrastructure support in these trials that you don't get in general community-based practice. You've got these really energetic research assistants who will hound you till the end of the earth if you don't show up, and chat you up and give you Snickers bars and do all sorts of things to make coming to the clinic more appealing. They give lots of patients find those interactions to be the most therapeutic aspects. Just the assessment. When we did the NIDA cocaine collaborative treatment study, we asked people, like, what was the most helpful thing in the study? These are folks who got twice a week psychotherapy for 6 months. One patient said, my meetings with the nurse, which was kind of interesting since we didn't have a nurse in the study. So I asked the guy, which nurse are you talking about? And it was a research assistant, the blinded research assistant, who only interviewed this patient twice, at 3 months and 6 months, just to do an addiction severity index. So I'm wondering, why was this nurse so effective? And I think it was because it was almost like confession. Did you use any drugs this month? Yeah, I used cocaine on 14 days. Thank you so much for telling me. There was no expectation. It was just, tell me the truth and I will be grateful. And that was, I didn't want to tell the therapist that had been seeing this person twice a week for 6 months that the nurse was so much better, but that's, you don't get that outside of a research study. So one study of a non-randomized study of Medicaid claims data in 5,000 patients with opioid use disorder, those who had at least one counseling or psychotherapy session within the first 8 weeks had better buprenorphine retention. Another study by samples that included some people here, retrospective study of Medicaid data, again, 5,000 patients. So most of the patients had either no psychosocial services outside of medical management or almost none. 17% had, quote, low intensity services. 9% had high intensity services. Retention was higher in the two groups that received some psychosocial services. Best for people actually who had the low numbers. But 32% were retained for over 180 days, which is seen as good retention, with no psychosocial services. So some people do well with buprenorphine and medical management and no other psychosocial services. So why might the low intensity patients do better than the high intensity? Because in regular clinical practice, if people aren't doing well, they get more services. So the ones who are doing the worst tend to get the most services. It's not like high intensity makes them worse. They just got them because they're doing badly. So, and the other thing is that the medical management in these randomized controlled trials, the 4 negative studies, might approximate the low or even high intensity studies in general clinical practice. So they were seen as often as the people that would there that you would say didn't get anything, I'm sorry, that got pretty high intensity services. Fourth question, are there subgroups that benefit from behavioral treatments? So in the prescription opioid study, we compared outcomes of patients with and without additional counseling among two groups of patients we thought it might make a difference. One, people with more severe drug problems, and one with people with co-occurring psychiatric illness. So more severe drug problems, the one area of severity, since we were focusing on prescription opioid use disorder, we excluded people who would ever, we didn't want people who were primarily heroin users. So we excluded anyone who had ever injected heroin or used heroin heavily. So we only had people who had dabbled a little bit in heroin. About 20% of people had ever used heroin. So if you look at this slide, this was, did drug counseling improve outcomes in people with more severe problems, meaning did they use heroin? So on the right side is people that never used heroin. That's most of our patients. And the red is people who didn't get drug counseling. The blue is people who got drug counseling. No difference. If you didn't use heroin, counseling, no big deal. But if you had ever used heroin, which was a bad prognostic factor, and you got, and these are people who were adherent, they showed up. Getting counseling gave you almost twice as good an outcome as not getting counseling. So, and the reason the heroin users had worse outcomes was all in this group. People who didn't get counseling. So what about people with co-occurring psychiatric disorders? By luck, exactly half of the patients that we had in this study had another psychiatric disorder. Those who had psychiatric illness had more successful outcomes if they received drug counseling. Those without didn't. So 61 versus 43, if you had psychiatric illness and you got counseling, same otherwise, and the interaction was significant. What about a specific disorder? We looked at PTSD. 19% of our population, those with PTSD were twice as likely to do well if they got psychotherapy. And if they didn't have PTSD, it didn't make a difference. So clearly there were specific subgroups of people who did better if they got counseling. Didn't mean as a group you could say, well, it didn't make a difference, but for lots of patients it did. What about mutual help group involvement? So as part of the prescription opioid study, we did a 42-month follow-up study of patients who entered the trial. And we were looking at correlates of how people did over time, like what led them to do well over time or not. And so people who were receiving agonist treatment had by far the best likelihood of opioid abstinence at the time that we assessed them, with odds ratios of 3 to 5. But people who entered mutual help groups, such as Narcotics Anonymous, Alcoholics Anonymous, also did better, odds ratios of 2 to 3, which sort of belies the idea that people who are on buprenorphine should not go to Narcotics Anonymous. Narcotics Anonymous does not view you as being in recovery if you're taking buprenorphine. So a lot of people don't want to go there. That said, the ones who went, who were sort of ready to hear that and sort of say, okay, I know you say that, but I still find this helpful, still did well. What about group treatment? There are different models of group treatment for people on buprenorphine. There's a shared medical visit, which is basically you have a group and a prescriber, or sometimes two, and Sometimes they do the visit like right there. You know, Joe, how are you doing? Are you having any side effects, et cetera? And sometimes they pull people out one by one. So there are a number of people who do that. There's group-based opioid use disorder treatment, just like any old group therapy, except all the people there are on buprenorphine. Both models seem feasible. The one where you're asking people about side effects and things like that, I see as a little troubling. But there are plenty of people who do that and say that they say patients seem okay with it. I'm not so sure. They're lower cost. There's no rigorous randomized controlled trials of versus individual therapy or versus medication management alone. Definitely need research on it, although group therapy research is daunting methodologically. Having done some of that, and good luck to you if you want to do it. What about other behavioral treatments? There's lots of other behavioral treatments that people are using. They're not well studied yet, but a lot of studies are ongoing on some of these. Case management, recovery coaches, sometimes called peer navigators. Sometimes people make a distinction between that, sometimes they don't. Mindfulness, exercise, yoga, acupuncture, telehealth, all of these things are going on. And people find them helpful. How helpful and compared to what, we'll see over time. But all of these things are being done. So given all of this, how to proceed? So consider a stepped care model. So things to think about. Many patients do well on buprenorphine and medication management alone, but we're really not very good at predicting who's who. There are limited resources for medical management and for behavioral treatment. Some patients don't want counseling. I remember reviewing a grant once in which they were comparing, it was in a methadone treatment program, and they wanted to compare carrot versus stick. So if you did well, you got more take-homes. If you did badly, you got more counseling. So that was the punishment. So both were seen as effective. You know, good. This is great news in the mental health world. So anyway, some patients don't want counseling. So understanding the importance of early treatment response may help in our decision making. So does early response to buprenorphine predict later treatment outcome? So we did a study as part of the prescription opioid study to look at that. So some medications like antidepressants, we know they may take a number of weeks to work, and if they're not working right away, you might say, wait and see how it goes, because it might work later. But we did, at least at that point, we didn't really know so much about the early time course of buprenorphine treatment, and that could be helpful in guiding us. So to look at that, we looked at predictive values, where positive predictive value meant, did being abstinent at the beginning of treatment predict that you'll be abstinent by the end? If you used opioids at the beginning of treatment, does that mean you'll be using at the end? So basically, does getting off to a good start predict a good outcome? Does getting off to a bad start predict a bad outcome? So here's the good start question. So this is predicting outcome at the end of treatment. So for us, it was a 12-week treatment, so we're looking at abstinence in that time period, weeks 9 through 12. So if you were abstinent in week 1, the positive predictive value, meaning what's the likelihood you'll be abstinent in weeks 9 through 12, is 49%. Coin flip, a little worse than a coin flip. So that doesn't predict anything. How about if you're abstinent in weeks 1 and 2? Goes up to 56%, and that's about as good as it gets. So getting off to a good start is good, but not great, because bad things can happen. But getting off to a bad start is really bad. So if you use in week 1, the likelihood that you're going to be using in weeks 9 through 12 is 80%. If you use in weeks 1 and 2, it's 94%. So there's almost no come from behind victories here. If you get off to a bad start, that's really bad. Now there's an asterisk here. The asterisk is, this was a study in which we were looking at the role of counseling. So we couldn't increase the level of counseling as one might do in clinical practice because of the way we were doing the study. We could increase the buprenorphine dose, that was fine, and it was done, but that, because there was no limit on that. So Sean Luo combined the data from our study with 2 other large studies from the Clinical Trials Network. Bless him for that. That was no easy job. And he found that the first 3 weeks, if you combine all of this, first 3 weeks were critical predictors of relapse. So we predicted good outcome. He was looking at bad outcome, but same general idea. So if you had negative urine tests in weeks 1 through 3, only 13% relapsed by week 9 through 12. If you had positive or missing urines, 85%. So the beginning of treatment really is important. It's important to hit the ground running when you start treatment. So I think what you can do is you can start treatment with whatever level of intensity the patient wants. Say, okay, I don't want any counseling, I don't want any of that. Fine, let's see how it goes. Some of those folks will do well. We don't know who, but some will, and some won't. But we'll know pretty quickly whether, which way the wind is blowing. And I think you can upfront say, why don't we start with this? And if things go well, we'll stick with it. And if they don't, I think we'll probably need to go to a plan B. That has not, we don't know that that will work, but it makes some sense. What about naltrexone and behavioral interventions? Behavioral treatments with naltrexone for opioid use disorder, because I already talked about it with alcohol use disorder, but it's a different deal. Adherence to oral naltrexone in opioid use disorder, I said here it's poor, it's sort of beyond poor. It's awful. And so oral naltrexone is ineffective for the vast majority of opioid use disorder patients. This was a major reason for the development of extended release naltrexone, the injectable form. There's some positive results for behavioral treatment to increase adherence, but it's limited. Contingency management, rewarding people for taking medication and/or negative urine tests, behavioral family therapy, observed medication taking, some of that, like a lot of the things I've been talking about, have been done here. So to conclude, a lot of factors influence the interaction between medications and behavioral therapy, the efficacy of the medication, the severity of the substance use disorder, and associated conditions such as psychiatric illness, the mechanism of action of the medication, the treatment goal, abstinence versus reduction, who's delivering the treatment, and the intensity and the context of the treatment. Thanks to NIDA for research support, my colleagues at McLean, the NIDA Clinical Trials Network, my colleagues here. These are some of the folks that I work with on a pretty day. And so I will stop and take any questions people have.